live telecast. And before going to the live telecast session, I request I will unmute mute the microphone of all participants except Bari sir, Samsuluda sir, and if we can find the shapes of sir, then we can unmute microphone.
Arif.
Yes, sir.
Shepsov is on the line. I don't know. He told me that he's not getting me. He's on the line. Can you see him?
Sir, still now I cannot find anyone named Professor Shepsov. Sir, can you ask him what is his ID?
1 minute. 1 minute. 1 minute, please.
I think he has not joined yet. There is no Russian ID. Dr. Arif, can you give me host so that I can start live?
Yes, sir. I am just.
Yeah, because it takes 1 or 2 minutes to go live. So.
Yes, sir. I am muting everyone now. Just a minute. Okay.
সে আমার কিছু কল দিছিল আসলে যে ট্রান্সফার ওয়েবসাইটে না মেসেঞ্জারে দেখো মেসেঞ্জারে দিছিল না ওয়েবারে দিছে
Okay, I delivered the host status to you, sir.
Okay. This.
Don't. Vladimir, we use Ashley. Vaš номер, Ashley, вы видите нас?
Dr. Arif, this is a...
Уже очень много людей из Нигерии, из Непала, из Индии, из Бангладеша уже все там, понимаете? Вы не видите нас. Вот Зумба, какой номер ваш? Ваш ID вы скажите.
This is lecture 11 or 12?
So, sorry, sir.
This is lecture 11?
Sir, this is lecture 11, sir. Basics of deformity.
This is lecture 11. 11.
Yes, sir.
Okay. Yeah, very
yes,
good
sir.
afternoon from Ortho TV side. This is Dr. Shamsulhuda from India, from Ortho TV, Ortho Worlds. Now we are, thanks to Bangladesh Kurgan Fellow Group, now we hand over to Dr. Arif to start the session.
Yes, sir. Please, can you deliver the host status to me, sir?
Sure. Yeah, it's done. You can start now.
Okay. With the permission of Professor Bari, sir, I will start the session. And
I need your permission. Not you don't need to take my permission. I need your permission.
Okay,
Shamsulhuda's permission, use permission, then I will continue.
Okay, sir. The participant from home and abroad, and all the foreign participants, especially from the Nigeria, and our very good friend Professor Shamsulhuda sir from India, and we already just had the information that Professor Shepsov is trying to connecting with us. I welcome Professor Shepsov. Still, I am not getting any ID from Professor Shepsov, so I hope that I will get a very soon connected with Professor Shepsov. Today, you know that the Bangladesh Kurgan Fellow Group organized this webinar, and it is the 11th session, 11 number lecture today. And everyone, you know that already know that the today's lecture topic is basic idea of deformity. The basic idea of deformity will be delivered by our mentor, Professor Mufakkarul Bari. As it is a formal webinar, so I want to go a few details of Professor Bari. Our Professor Bari sir had his MD and MS from Kiev, and PhD from the Tashkent, and he is a postdoctoral fellowship from RISC RTO Russia, and he is also limb lengthening and reconstruction fellowship from Chennai, India, and he is visiting professor of RISC RTO Kurgan, Russia, the Ilizarov Center, and also honored professor in Weifei University, China. He is the chief consultant in Bari Ilizarov Center. He is very renowned and very famous Ilizarov Center in Bangladesh. And you will be happy to know that all the Ilizarov surgeons that are working in Bangladesh is somehow related to Bari sir. Most of them are the direct student. So we all the Kurgan fellow are the direct student of Professor Bari sir, and every time we enrich our knowledge with talking with our professor, and he is very much generous to deliver all of his knowledge to his successor. So I request Professor Bari sir, please share your screen and start today's session. Sir, everyone who have the question for to this session, and you will send me the message in the chat box. And they are already, I got a picture from a foreign participant to be discussed in this session after the lecture of Bari sir. Bari sir, if you can hear me, please start your lecture, sir.
Okay.
Share his screen, sir. This.
Okay. Can you?
Yes,
can
sir.
you hear me?
Yes, sir. We can hear you.
Okay, Arif, thank you very much for your nice words. My dear friends, participants from home and abroad, especially from India, from Nigeria, from Nepal, from Russia. I am very much grateful to you all, and today I'll talk on deformity. Before going to deformity, I have divided my lecture into 3 parts. First of all, I'll talk a little bit regarding the Professor Ilizarov, academician. Next, a little bit over his technique. And then I'll talk on the principles and normals, what is in our body, and how to correct the deformities that we face in our day-to-day life. Professor Gabriel Abramovich Ilizarov graduated from the then Soviet Union in 1943 at the end of after the Second World War. And after his graduation, he was assigned to work in Kurgan, a small town in Western Siberia. You know that. And he was the only physician within hundreds of miles and had little in the very ways of supplies and medicine. Faced with numerous cases of bone deformities and trauma victims due to the Second World War, Professor Gabriel Abramovich Ilizarov used the equipment at the hand to treat his patients. And through trial and error, with handmade equipment, this self-taught orthopedic surgeon created the magical combination that would cause the bone to grow. Thus, the Ilizarov technique was created. This is about the Professor Ilizarov. And the main thing is the Ilizarov technique. The day before yesterday, we talked about the Ilizarov technique and distraction osteogenesis. This refers to the formation of new bone between the 2 bone surfaces that are pulled apart in a controlled and gradual manner, which gives you the new vessels. That is, we call it neovascularization, and which is actually simulates the new bone formation. In addition, there is a histogenesis of the muscles, histogenesis of the nerves and the skin, and in diseases like osteomyelitis, deformities, fibrous dysplasias, and pseudoarthrosis, this new bone replaces pathological bone with a normal bone. This is a revolutionary concept in medical sciences. Diseases for which earlier there was no treatment possible can now successfully be treated with this Ilizarov method. So this is about the technique. Now, Ilizarov Center, it was my dream went to visit the Ilizarov Center since my residency. Ilizarov Center is the origin of deformity correction. My dear young generation fellows, you should know that the origin of deformity correction, limb lengthening, and pediatric orthopedics, and treating the osteomyelitis. I have given my best efforts to learn and acquire Ilizarov technique, and Ilizarov Center has gained me and given me and guided me towards achieving my goals. And probably I think I have achieved a little bit with following the Ilizarov Center. Now, I will go to the, you can see in the picture first, Professor Gabriel Abramovich in the Ilizarov OT. See, this is my training places. This is the center I want to show. I love to show this center, the orthopedic capital, orthopedic center, largest in the world. And Muslims, they call Mecca. They go to the Mecca, but orthopedic surgeons, they should go to the orthopedic center, the Ilizarov. Here, you know, the statue of the Ilizarov, you can see there, the law of tension and stress is written there. Slow and steady traction on a living tissue that creates a, what is new bone formation, and which is metabolically activated and which gives histoneogenesis, tissuegenesis, angiogenesis, neurogenesis, all genesis. This is written here, the law of tension and stress in the statue of Ilizarov. This is my center where I worked here more than 10 years. This is our Nitour, and I myself, there you can see here all the faculties, and you can see Ghulam Farooq is also here, but all are now retired person. They are working in their individual places. So this is my center, 40-bedded Ilizarov Purely Center, and this is, I love to see my mentor, my professor, Vladimir Ivanovich Shevtsov, academician, and now you can see the varieties of deformities. You can see how they are working. Jumping, crawling, twisting, and these are the varieties of deformities. Look at these. And a little bit only I have shown here, a little bit. Next, I proceed. Now let us see what is normal, what is abnormal. Some basic terminologies. Most of the orthopedic surgeons, they know it. I repeat it for your kind consideration. You see 4 things here: joint center, joint line, limb axis, and joint orientation. See, hip joint, point is the center of the femoral head. These are the 4 things. The center of the femoral notch, you can see here. You can see here. Center of the tibial spine here. Center of the femoral condyles, and center of the soft tissue. This is the soft tissue here, both sides, and center of the tibia. These are the 5 things, basic things you should have to know. Joint center, you can see here in the ankle, center of the soft tissue, again, center of the bones, and center of the talus. So if see any shift here, if you know these normal things, then you can easily identify what is the problem. Now joint lines. Proximal femoral joint line, line from the tip of the greater trochanter to the center of the femoral head. Now you can see distal femur joint line, line tangential to the most distal points of convexity of the femoral condyles. And then see 2 plateaus, medial lateral plateaus, depression post. If you draw a line, then you'll see the line across the concave aspect of the tibial plateaus. And distal tibia also equal to dome-shaped patella. Here, if you draw a line, this is called the tibial plafond dome of the talus. And limb axis, mechanical axis, anatomical axis for the newcomers. You must know all these 2 axes. Mechanical is a straight line that connects the joint center, the proximal and distal joint. Anatomical is a mid-diaphyseal line of the bone segment. So these are the basic things. An axis of the femur. Here you can see the mechanical axis. Here is the anatomical axis. You can see here mechanical axis and anatomical axis. To the 3 points from here cortex to cortex, cortex to cortex, and then you draw a line center. This is your anatomical axis. Mechanical axis, call it weight bearing axis, center of the hip, and then you go to the center of the knee. And next you can see here tibiofemoral angle. If you do any surgery, not only Ilizarov, you should know all these angles. See, anatomical, mechanical axis, this is 6 degree, or sometimes you can say it's 7 degree, and axis of the tibia, mechanical axis and anatomical axis of the tibia almost the same. And now joint orientation angles. My dear friends, engineer colleagues, you should have to keep it in your mind. This is the main thing, that the 4 angles, LPFA, if you see the LPFA here, and here is the 2 angles opposite, 87, 87, LDTA 90, LPFA 90. What are the joints? If you see regularly, you will memorize it in your mind. 1 time, 2 times, you will not be able to memorize. So, and joint orientation angle. What is that? LPFA 90 degree. If you take the hip joint orientation angle between the hip joint line and the mechanical axis of the femur. This is on an average is 90. So here you can see joint orientation angle, knee joint orientation, LDFA, MPTA. These are the very important things, LDFA and MPTA, and JLCA, joint line convergence angle, 0 to 2 degree. To keep it in your mind, you must know the 4 angles. I told you before, these are the angles, 4 angles, 90, 87, 87, and 90. LDTA 90. Distal, lateral distal, tibial angle, 90 degree. So it is very easy to memorize, 90, 87, 87, 90. These are the things you can easily remember here. See, this is the 90, this is the 90, LPFA, and this is 87, opposite 87. If any problem near the joint, then you will realize this 87, this is 87, and LDTA, this is 90 degree. So you can see here 4 angles. Keep it in your mind, 90, 87, 87, and 90. Next. Now, regarding the understanding of the deformity correction, you can see here, before embarking any kind of deformity correction, please remember the 10 things. 10 things. Is there is deformity or is bone is deformed? Number 2, source of the deformity, whether it is congenital or acquired. And where is the deformity? You must know the level of the deformity and the plane, in which plane. This is in anterior posterior, sagittal plane, oblique plane, or in which plane. You should have to identify that one before embarking the deformity. And you can see the magnitude of the deformity, what is the degree of a deformity, and where to do the osteotomy. You must know in which place you should do the osteotomy and which kind of osteotomy you are doing. That is the type of osteotomy. You should know that with the Ilizarov surgeon, we are always using the Ilizarov external fixator. That's why we are doing 1 type of, or 2 types, or 3 types of osteotomy. And whether we are correcting this, you are going to correct this acutely or gradually, and which kind of hardware fixation, either internal or external, which one is going to fix, you should have to know that one. And very important thing, dear friends, never operate on the wrong bone. These are the 10 understandings of deformity corrections. Now, if you think about it, I am okay, you're okay. That means everything is okay, no problem. I am okay, you are bent. That means you have a problem, and how to measure that problem. And always gaming with your brain, intelligent games, deformity options, which options you should correct, and treatment strategies. Now, approach to the deformity correction. 3 questions have to be answered always. Is the limb normal, or the limb is aligned, If the limb is not aligned, where is the malalignment? And question number 3, how to correct the deformity? If the limb is normal, then we shall have to think about this. A normal limb is an aligned limb. Hip, knee, and ankle joints all are collinear to each other. Abnormal, not collinear to each other. And we shall have to think about the mechanical axis deviation. Here you see normal mechanical axis deviation 0 to 8 mm. And look at this deformity. Just look at. I'll show you later on this. If the limb is normal, if the mechanical axis is normal position, it is aligned. If there is mechanical axis deviation more than normal, 8 millimeter, medial to the center of the joint line, limb is not aligned. Now, normal alignment parameters. In mechanical axis, you can see here AP and lateral sagittal view. Sagittal, 3 things. Only you should have to remember this here. Here I have repeatedly told you 90, 87, 87, and this 90. Here a little bit one, you know, just forget about this one to keep it in your mind. Easy, 87, 87. This is 89, this is 90 is okay, this is 90 okay. Otherwise, you will not forget. And in sagittal view, see PPFA, proximal femoral, see angle here, 90 degree. PDFA, you see laterally 83, 83, 90, 83, 81, and this is 80. From top to below, in sagittal view, up is 90, then 83, then 81, then is 80. So these are the angles. You should have to keep it in your mind for deformity correction. Now let us see the some alignment test. Varus deformity and valgus deformity you'll see in your day-to-day practice life. Lateral mechanical axis always denotes the valgus deformity. You can see here, this one. And medial mechanical axis denotes always varus deformity. And I'll show you later on, you can see. Question number 2, if the limb is not aligned, where is the malalignment? Question number, you can see, you shall have to identify the location of the malalignment. This is seen by joint orientation angles. I have repeatedly told you LPFA means there is a deformity where you can see, and LDFA, there is a deformity in the lower femur, MPTA, mechanical, medial, proximal, tibial ankle deformity in the upper tibia, and abnormal LVT means there is a deformity at the ankle. And now in varus mat, you can see here, dear friends, only just for your MPTA, normal 87, here is 85. That means problem is here. And LDFA, lateral distal femoral angle, you can see here is 90, this is normally 87, this is 85, this is 80, here is 90, that means greater. And next one, both deformity in the tibia and the femur. So our full joints, this one, femur and tibia, both are affected. Now in valgus, you can see here, MPTA here, if you see the MPTA, this is 90, it is normally 87, this is 87, this less than 85, former is here. So both distal tibia and femur, you can see the deformity. What is the source of deformity? Dear friend, now you can see the source of mechanical lateral distal femoral angle. Here is 94, this is 87. So the problem is here, this is normal. This is mechanical axis deviation. Again, you can see here, this is 94, this is 82. Problem is both the femur and tibia, upper tibia. And JLC, joint line orientation angle, it will also change. Normally this is 0 to 2 degree. See, look at this, same. JLC here you can see it is 7 degree, joint line convergent angle. And now alignment source, you can see here, femur, think about the femur. Here is 94, here is 87, this is normal, here is 82, this is 94, this is not normal, this is not normal, and JLC here you see 7 degree. So depending on your deformity, you should have to take decision where you will go for osteotomy. Now rotational deformity, dear friends, high foot axis, you can see this is normal, this is positive, This is negative. Tibial torsion, patella forward. You should have to think about the rotational deformity of the tibia. Now let us see the rotational deformity of the femur. See, rotated 45 degree. This is also 45 degree. I put forward. Now, if you see your problem in the hip angle, don't affect the mechanical axis. Look at this, your problem in the here, LPFA 115 degree, here is LDTA 90 degree. This is 90, it must be 90, it must be 90. Here is 70, so 20 degree problem. Here is 90, 115 degree, 25 degree problem. How to correct the deformity? For this, we have to identify three things: level of cora, true apex of the deformity, level of the hinge, which place you are going to place the hinge, and level of the osteotomy. These are the very important things, dear friends. And center of rotation of angulation of the deformity. This is cora, you know, that is true apex of the deformity. Now, I will sequentially go for this cora and magnitude of deformity. Now you can see here normal femur and varus tibia. You draw the axis, mechanical axis, and you can find here the problem in the distally. You can see here 30 degree. You draw a mechanical axis, this is the magnitude, this is 30 degree. Total our 180 degree. If you cut this 180 degree minus 30 degree, 150 degree, if you draw a bisector line, I'll show you later and that it will be half. Now see, bone can be divided into proximal and distal segment. Now you can see here, cora is the intersection of the proximal bone axis, and surgeon has no control over the level of the cora. This is the true apex. You have drawn a line, this is the angle magnitude. This should be correct. This is the bisector line, tibial bisector line. This is the true apex of the deformity or center of rotation of angulation. Now, Ilizarov fixator has broadly two components. Number one, hinge, and number two, rings and pins. Hinge by which you correct any kind of deformity. Professor Ilizarov and Professor Shipsov always told all the time, you give me the hinge, I will correct all kinds of deformity. By which rings and pins, we can fix the Ilizarov fixator. Hinge is the most important component of the Ilizarov apparatus. And surgeon has complete control over the level of the hinge, dear friends. Mind it, if you mismatch the hinge, you are doing wrong. And this is the speed of correction, rule of triangle. Very easy, you can correct and you can get a Y-shaped bone. This picture I have taken from the Kurgan, these Russians, they have made like this, you see, very good picture. Do osteotomy here, and gradually you go for the destruction. And normal femur, varus tibia, metaphyseal deformity. Think about this, how to identify the deformity. See here, see magnitude is here 12, and tibia is depressed, and this is your LDTA, lateral distal tibial angle is 90 degree, this is normal. Or here is the deformity in the upper tibia, that is 12 degree magnitude. You should correct that one. Now let us see some scenarios depending on the deformities. Genuvarum, see, young chap, look at this. Genuvarum with placement of the hinges and with olives. See, genuvarum, this is young chap, corrected, and after 8 months you can see the follow-up. Good regenerated bone, axis is okay, no problem. Scenario 2, same varus deformity, the upper tibia shortening. Look at this angle. If you have to draw yourself angle, then you can easily think yourself how much magnitude of deformity you should have to correct. So this is during treatment, and see, dear friends, after 5 months, good regenerate with good correction. Look at the left side and look at the right side. So normal femur, distal tibia varus. Here you can see 88 degree LDTA. Here is magnitude is 40 degree, and upper portion femur and knee joint is okay. So normal femur with distal tibia varus. Now I'll show you the scenario. See this one. post-infective left tibia with ankle varus with shortening, young chap. Look at this. If you draw a line, lateral view and AP view axis, see, look at this placement of the hinge. Only the weights, biocompatible thin weights. I never use any kind of shunts in the tibia. This is the teaching from the Kurgan. So these biocompatible thin weights by which you can correct any kind of deformity in the tibia. So radiological view, before and after, you can see good range of wide correction and good regenerated bone. Lengthening is also achieved after 11 months. Now see this young lady came to me with the recurvatum and varus deformity. Look at this. If you think about this, this is okay more or less. No, the patient was always complaining. Then you draw the line, see the coda, and put your a little bit osteotomy. See, I have been the 90-degree hinges, and then everything is okay during treatment. Look at this. Finally, you see this one, how much I have corrected after 1 year. Look the left side and the right side of the X-ray. Recurvatum is totally corrected, and anatomical axis is corrected. Patient does not have any complaint, and she is doing well. Dear friends, can you hear me sound here?
Sir, very less sound.
Yes, sir.
Best sound?
A clear sound.
Clear sound?
Yes, sir. Clear sound.
Okay, sir.
Clear?
Clear.
Can you hear?
Yes, sir.
Yeah.
Okay, then here, listen this.
Nazmul Sir is asking about the video sound. Can you hear the video sound?
No, video sound is not here.
This video is not here?
No, video sound is not audible.
Okay, okay, then listen. See this one. See this one. This is the angulation. And if you put your hinge in the top a little bit, in the apex, in the convex side, and go for gradual destruction, you are getting a little bit opening wedge, and your line is collinear, axis is okay. Bone. You are getting a degenerate bone. Collinear. Procedure rule number 1. That means if you put your hinge over the true apex of the deformity and do the osteotomy, you are correcting without any translation and angulation. Away from the coda, and then if you go for destruction, you are getting a opening wedge, degenerate bone, and line is okay, opening wedge, bone. Like this, then if you do it like this, if you correct the deformity, you will see the bone is, you are making your bone shorter. Or smaller. Angulation. You will not get any kind of translation and angulation. Now another type you can see here, this is the angulation. If you put your hinge at the concave side away from the true apex of the deformity, and if you go for correction, you use line. This is the bisector line. Then if you compress, this is compression type of deformity correction. Shorter. And now three things another you can see. This is your angulation. If you put your hinge away from the true apex of the coda, and the same center. And if you gradually correct, you will get a wide range of regenerated bone without any translation and angulation. Right. You are getting wide range, lengthening your bone. Another view, you can see here, if you put your hinge true apex of the deformity, put your hinge back to the true apex of the deformity, and you are getting wide range of regenerative bone with translation and angulation. Now, finally, you can see if you put your hinge that in front of the top of the convex side deformity, then you are getting, and you are correcting, what you will get? You will get a wide range of regenerative bone with translation and angulation. And your proximal one is going down and distal one is going up. This is the placement of the hinges. Now, osteotomy level, surgeon has relative control over the osteotomy side. It depends on the condition of the bone and the soft tissues. Now, dear friends, see the rules of the osteotomy. Rule number 1, if you go for this, see this one. Here is the Aka axis, that you are getting this and you are getting this. See this one, you can remove a short video and widening this. This is the osteotomy rule number 1. So, now let us see the osteotomy rule number 2. If your ACA angulation correction axis angle, then if you do your osteotomy below the coda, there you are getting a correction with angulation and translation. And this is osteotomy rule number 3. You can do like this. You see, this is the coda, and you can, if you do the osteotomy here, you are getting a parallel, you know, bone. This is not, axis is not in the same collinear. Now, dear friends, osteotomy principles. I told you this is the bisector line. Bisector line. This is the bisector line. Here you can see the true apex of the deformity. This is the opening wedge. This is tibial bisector line. This is closing wedge. And you can do with this way, you can gain the length or you can lose the length. So this is osteotomy principle. Next, we can see here rule number 2. If you see here, this is your coda. This is your coda, true apex of the deformity. 3 things here: opening wedge, neutral wedge, and the closing wedge. See, look at this. If you do the osteotomy here, you are getting this kind of here. If you remove a part of the bone, you are getting this kind of correction. And if you do the below the coda, that it will come like this. Here, LDTA, how much? I told you 90 degree. Here is the 70 degree. So you should have to calculate this one. Draw a line here. This is 20 degree. Remove this one and you shift this one. You can put the Ilizarov here and you will correct. You will getting the LDTA 90. Here is the 70. So you have corrected 20 degree LDTA. Now, dear friend, normal tibia and varus femur. Your tibia is normal. Femur is problematic. You should have to identify where is the problem. Same, you go again. Scenario 5, you can see here. Varus femur with implant failure with a 3 centimeter LLD. This is here is the implant failure, broken implant, non-union, 20 degree of the implants. Now, see, you can see the JLCA is a problematic, joint line is reduced, joint space is reduced, your deformity is 20 degree. Then we have to, what we should have to do that one, we have done remove the implant and we achieved union with Ilizarov. See, good formation, good stability, and good ring fixator in the femur and in the tibia. And then we have done after 6 months. Correction was achieved, union achieved, but the problem with the knee, stiff knee. Patient cannot tolerate a stiff knee or a stiff elbow because everybody wants to sit. So I have done the Judaeus quadriceps plasty. Same patient before and after. You can see after 6 months follow-up, you can see the length axis. Axis is okay. This is before, this is after, this is only after 6 months. Then you can go for, this is after Judaeus quadriceps plasty. Same patient, Judaeus quadriceps plasty. After 4 months, you can see patient can do the 90 degree. We can say this is the normal for the stiff knee. So now sagittal plane, deformity is dear friend here. Only the calculation, mathematical calculation. So Ilizarov, first alphabet, intelligent. You must be intelligent. You should have to calculate everything with your brain. See here 20 degree in lateral view, 20 degree tibial osteotomy you should have to do here. See, look at this. Femoral osteotomy, you can see how much, 20 degree. Very easy. This is not difficult. Only you should have to think yourself, here 20 soft tissue lengthening we have done. You should have to do, not we have done, you should have to do. This is a sagittal plane deformity. This is C, LDFA. If you know the angle, all the angles, then it is very easy for you to correct the deformity. See how to correct here, 8 degree, 12 degree. Now let's proceed. Now, dear friends, multiple deformities. Here that young girl, I have shown you, you can do this way and that way. We have another thing is this, doing deformity, see multiple. Femur, joint orientation line, joint orientation angle. This is 90 degree, but your cora is here. But I can see here is the pseudo cora. You can do the pseudo cora means 2 coras here. You can draw the 2 coras here also, and you can measure the angulatory deformity here. See scenario 6. Look at this. Here is the tibia. If you look at the femur and tibia, both are deformed. If you draw one line here from here and then draw a line here, this is your axis. Then if you draw it from here to here, there will be 2 coras here, 1 cora here, 1 cora here. This is called pseudo cora. And you can do the correction of 2-level osteotomy here easily. Here I have done the 2-level osteotomy here. You can see 1 osteotomy here, 1 osteotomy here. 2-level osteotomy for beautiful correction and placement of the hinges. Placement of the hinges. Now you can see next after 6 months follow-up. This is after 6 months follow-up. Same girl, see too much ricket, see the backside, fantastically corrected with only the biocompatible thin wires. No shunts, no hybrid. Now scenario C, same, these are the difficult cases. I'm showing you the multiple deformities. If you see these kind of deformities, don't be afraid. Bone quality is not good. You can put shunts, but it is very difficult to place the shunts and to hold the shunts with the bones. And these biocompatible thin wires help you to deviate any kind of deformity. See, during treatment, I have done the osteotomy. I have translated a little bit. Now you can see the axis in the AP view and lateral view. Now see, the bones are corrected. This is before, this is after. Okay, see, look. See, college teacher, government college teacher, very difficult case. At the age of 32, he came to me to correct his deformity, multiple deformities. Deformities in the knee, deformities in the ankle, and deformities in the foot. After 8 months only, and 9 months follow-up is working. See, look, see the patellar trachea. Patellar trachea. Where is the knee? Where is the ankle? Where is the foot? Now he's too much happy. He's a college teacher, government college teacher. Rate of deformity correction, structure at risk, concavity of the deformity correction. You should have to think about the bone, soft tissue, not more than 1 millimeter per day, tailored to a specific patient based on post-operative assessment. You should have to do everything. Scenario 9. Same, dear friends, problem in the femur, problem in the tibia. Same. After 1 year. Now look at this. Right hip, 39 years old man with Coxavara. How to treat? See the angle, see the trochanter, and see the whole pelvis. I have done the osteotomy. Look at the angle, center of the head. See the center of the head. I've done the osteotomy here. You just put one shunt here, and these are the console wires. One shunt here, deviate, angle is corrected, and I have lengthened. This is 1990 hinge, and patient is happy. And ongoing treatment means due to corona, patient is talking with me with all the time. I was supposed to remove the apparatus. Very bad case, dear friends. Just you look, when you will gain knowledge, you will be expert. You can do any kind of deformity correction. Look at this. After 1 year, look at this. After 2 years, 12 years. Now, see again, juxtaarticular deformity. If you look at the knee here, you will not be able to understand what is the situation of the tibia, upper tibia and femur. Very difficult. See how she is. She came to me, not the Rohingya, she's from Myanmar. She came from Myanmar for treatment and treated this lady. Look at this, depressed, whole depressed. Here see, not medial condyle plateau, you cannot see. And here I have done the opening wedge osteotomy with hinges, multiple wires, and nothing else. And gradually we have corrected. See here. Now if you see here, this is depressed. Joint, think about the joint. Joint is gone. So, placement of the hinges you see, I have placed this wire. Now she's, and then next step, see, I have elevated this, how much degree you can see here. Again, I have elevated, I have done the osteotomy here, and gradually I have elevated this one. And what I have done, next you can see here, the elevation of the medial condyle, almost the same. This is okay. There is a little bit problem in the joint line orientation, but you see the deformity, see the ankle and the foot after 1 year. Patient is happy, I am also happy. Now look how she is walking after 2 years follow-up, after 2 years follow-up. It's a beautiful girl with deformity, multiple juxtaarticular deformity. Fibrous dysplasia, dear friend, was not good. 3 times operation was done, this case. Then I have removed, done the osteotomy with multiple K wires and console wires. I have corrected this one. This is during treatment. Now see the bone quality before and after. This scenario, this is a very difficult case. This is the daughter of our medical director. She went outside our country and she was supposed to go for amputation. I showed this case to Dror Pale after doing this. He was astonished. It's very good. See, look this case. See the bone. Then deformity, and this is, you can say, the super. See the, and see patient is walking before and after. These are the deformities. Then you can meticulously correct if you're sincere, if you're devoted, if you're dedicated. then you can do something. Patient is very much happy. She's my Facebook friend now. See, dear friends, do you think this is very difficult? No, I always tell no, difficult. Stiff non-union. See, what I have done, you know, most of the orthopedic surgeons, they know, they put the ring with wires, and I have done the only osteotomy in the fibula and gradual distraction. See, gradual distraction, osteotomy in the fibula here, you can see, and gradual distraction. What happened? After 4 years, infection. After 5 years, now after 6 years, see the follow-up. And this is after 10 years follow-up, you can see here. So bone quality is good, everything is okay, long follow-up. So monkey mouth, see the AP view and lateral view difference. Good quality of bone here, good quality of bone here. You don't need anything. If you know the Ilizarov, you can help lot of things this kind. See, look what I have done. Only the rings, 2 rings with telescopic rods, not telescopic, with hinges, and go for gradual distraction, hypertrophic non-union. You can correct the deformity, shortening, and you don't need to put any bone graft. After 8 months, see the long follow after 6 years, bony bump, monkey mouth, just like a mouth, just like a monkey. See, this I've given the name monkey mouth. Now you can correct. See, after 6 years follow-up, body bump before and after. See, so the backside. So patient is working in foreign country. He is now foreigner. Deformity. Only calculate. See, only calculate. Only calculate. Now go fast. Dear friends, one devastating injury case. He has taken to the OT for amputation. Took it as a challenge. See the fixator in situ. See the calcaneum, black skin. Day 1 in OR. After 4 months, compression distraction by Ilizarov. And 5 months, 7 months, 9 months follow-up. And now see the front and back after 11 months. A little bit limping, it doesn't matter. The patient is walking with his own bones, own leg. Now, almost I'm going to bad case 1. Everything cannot cover all the time. See, look at this. And this case, I would like to show you. This was the case of following the knee dislocation. He was treated elsewhere, and that patient came to me with big ulcer lateral border of the foot with equinus and plateaus. See the plateaus, equinus, and big ulcer. Then I know the Ilizarov in my head, philosophy and principle I know. Then I took him, principle and philosophy. See the toe, dear friends, toe, and putting the wires here. See it, radiographic smiling patient with healed ulcer. I have put the multiple K wires, wire technique only. See clinical appearance of the patient after 5 months, and final clinical appearance of the foot, that all the toes which was gangrenous was everything healed. There was a vascular impairment after the following the knee dislocation. So now this is post-polio 1, post-polio deformity. I would like to proceed quick before correction. See, knee, ankle, and foot deformity. So proceed fast. This is C, relapse CTB. PMR was done, 14 years. Irani girl, look at this, bony deformity in the midfoot, forefoot, and hindfoot. Then 4 months follow-up, look at the toes in a standing position. And one case I'd like to show you, upper extremity I have not mentioned. I talked about the deformity lower. You can do also upper extremity, see? And this is the video. See before, the deformity at the wrist and shortening. And this is during, and this is after. So stages of preoperative planning. This is very important. Determination of the true deformity quota, calculating of the amount of deformity correction, biomechanical designing, determination of osteotomy level, determination of the osteotomy shape, and selection of the deformity correction. This is I've taken from my, when I was the student in Kurgan. See, a diagram so beautifully from Kurgan. See how to put and how to do this. See, this is also from Kurgan. See, here, regenerative bone. This is trapezoid Y shape, regenerative bone. How can do very easily. See also amount of bone formation, trapezoidal regenerative bone. Stages of the osteosynthesis of the leg bones, you know, insertion of the wires and others, placement of the hinges, especially how to place, when to place, why to place of the hinge, very important for deformity correction. Skin incision, approach to the bone, osteotomies, deformity correction, partial or complete, or skin closing, and check X-ray all the time. Main principles of transosseous osteosynthesis for deformity correction: insertion of wires with stoppers, that is olive wires, in the process of deformity correction, and hypercorrection of the external supports of the transosseous fixator during its mounting, proper and efficient arrangement of the fixator hinge parts, units. See, this is also very beautiful drawing from the Kurgan. See, you can variant of fixator configuration for correction of the deformity, leg upper third with knee protection. This is, you can protect the knee, placement of the hinge, do the osteotomy, only telescopic rock, then you can easily correct, and you're getting a very good regenerative bone here. The axis is okay, hinge is okay, everything is okay. Next slide, you see this a variant figure of correction of the valgus deformity of the leg, upper third. How we can put, see the placement of the ring, wires and hinges, and gradually you correct, you will get the correction, good correction. So this is another variant. Stages of post-operative management, gradual of residual deformity, proper dressing, very important. In Kurgan Center, they are doing very nicely. And I always try to follow this proper dressing. Adequate functional and static weight bearing of the limb, efficient exercise therapy. Dear friends, putting the Ilizarov apparatus and you are not doing any therapy, that is not good. Controlling the regenerative bone condition all the time after doing the X-ray. And periods of fixator removal are determined by following the mean periods of consolidation depending on the amount of deformity, limb shortening, patient's age and etiology, the presence of the X-ray signs of newly formed bone, and the data of clinical testing the consolidation stability. You should have to keep it in your mind. And principles of removing the transosseous fixator, adherence to the indications for the fixator removal, consolidation, clinical signs, and X-ray, and of course the sound anesthesia, very good anesthesia. A patient should observe the following after the removal of the Ilizarov fixator. Axial and functional loading of the limb should gradually increase. Adequate exercise therapy could continue. Regular procedures of physical therapy and control of subsequent examination for all the time. Tactical errors, the wrong selection of the number and the levels of the osteotomies. The faults in the calculations of the limb segmental deformity and shortening, neglecting the disease etiology and the patient age. These are the tactical errors. And what about the technical errors? In the preoperative period, the wrong selection of the Ilizarov fixator supports and the parts. While performing surgeries, non-observing the rules of the wiring session, biomechanical principles of mounting the fixator supports and units, making osteotomies, neglecting the creation of soft tissue reserve during wiring session and fixation. These are the technical errors that you should have to keep it in your mind. The errors should be kept in mind post-operatively. Dear friends, see, unreasonable, frequently changing the fixator, non-observance of deformity correction rates, the absence of timely X-ray control with dynamic regeneration, incorrect interpretation of X-rays, premature removal of the fixator, underestimation of the importance of exercise therapy and the possibilities of early limb weight bearing with the fixator applied. And complication, of course, you should have to keep it in your mind during treatment. You should have to face a lot of complications. If you don't do meticulous, intelligent follow-up, you will get a lot of problems. And the problems you can overcome all the time very nicely. See what are the equinus deformity, knee contracture, pseudoarthritis formation, subluxation. These are all depends on your placement of the hinges and meticulous follow-up. So, dear friend, this is a bridge. You see, a tension wire having a bridge. A wire working on a tension wires. So, Ilizarov wires always gives you the proper tension. If you apply the proper tension, you will get a good result. Living with Ilizarov frame. See, lady beautiful, doing exercise, child with Ilizarov. Everybody is telling all the time in the femur cumbersome. What do you mean by cumbersome? I don't understand. Cumbersome. Now I'll show you a picture cumbersome. See, my request, those who are doing the Ilizarov surgery in the femur, please make this kind of trolley. And in my center, I have my all beds are like this here, all like this, so that patient can take comfort. You can give comfort. Otherwise, if you don't give comfort with ring fixator in the femur, if you don't do a space here, how patient will sleep? Now see, cumbersome in the femur. Patient is doing exercises. This is in my center. With exercises with femur, you lift up. The fundamental principle of Ilizarov methodology is load and motion. This is they are giving load and motion. Put the Ilizarov. If you don't give any motion, if you don't compress, then you cannot get good outcome. You cannot get good regenerate bone. So this is the beauty of doing Ilizarov surgery. See, patient is doing exercises with femur. This is not a matter of joke. If you properly place the fixator in the femur, patient can do, patient can walk. I showed you one with this. And in conclusion, dear friends, in cosmesis and deformity correction, excellence is achieved by correcting the correct deformity at the correct corner. That means in the correct place to the deformity based on correct planning, by the correct method to achieve the correct correction. This is my conclusion here. And yesterday, that day I talked to you trifocal bone transport by Ilizarov technique. You can see here acute shortening and lengthening. Sorry, acute shortening. Here you can see acute shortening lengthening monofocal approach, single level bone transport bifocal approach, and double level bone transport. This is called trifocal approach. This is the cases, and this is published in February 2020 this year. So these are the publications. I cannot show you all these things. This is fibrous dysplasia, correction of the bone deformities, Judas Crafty. You can go through in MedCrave American Journal. These are my foreign fellows. You can see from Nigerian fellows, Indian, British, and Korea. And this is Obinna. This is from Amba. This is from Jordan. This is India. This is from UK. These are all from Malaysia, Nigeria. This is my foreign fellows. So this is first time we did our conference 2009, where our health minister, Professor Rulock, was present. This is now the director, Ghanimullah, ex-director, Abdullah, Professor Rizvi. This is the Russian ambassador and Professor Shepsov there. And we conducted the first conference there. And this is all our Bangladeshi Ilizarovians. I love to see all the Ilizarovians and Indian friends. I don't see the Shamsuluda's picture here, but he was with us all the time. So the man who made it possible, great scientist, talented doctor, gifted innovator, creator of the apparatus, method, transosseous osteosynthesis, academician, Russian academic of medical science. A physician must observe nature, learn from it to be able to rectify its flaws. 15th of this month, the birthday of Professor Ilizarov, and we are going to observe that one. We have in Kurgan Center, there will be a webinar conference, and we'll join them. It is my dream that this was given to me from the Ilizarov Center. And Shepso Professor, I always remember him, respect him from the core of my heart, and probably he's listening about this webinar session. And see, these are all stalwarts. Dear friends, I must say you, this man, Professor Oganessian from Central Institute of Traumatology in Moscow, he was the rival of Professor Ilizarov. Oganessian technique, he was teaching me, he was using all the time half ring, Oganessian apparatus, and he was my opponent when I was doing PhD. Professor Mir Hakim Azizov, he died 3 months back. Professor Arjagast, creator of our National Institute, and this was the Americans. They are the followers of the Broad Palace. I did this operation in Miami earthquake with our friend, junior friend, Mona. I did this surgery, and you know this, and this Kulkarni, I must pay respect all these. And this is the daughter of the Professor Ilizarov, Svetlana Ilizarov, Arjenberg, Ketagny, Jamalustino, Teswat, Milind, and Fernandez, and Korean, my friend Korean.
It was a song.
Challenges in life, only 2 minutes probably. 3 categories: easy, difficult, and impossible. Who take the easy way have a safe and boring life. Those the difficult way have a tough, satisfied life. But those who are taking the impossible way are remembered forever. And I love to do the difficult and impossible things. And boldness should not exceed one's skill. Whenever you do anything new, everyone will be ridiculed. They will laugh you. In starting point, they will laugh you, ridiculed. And then time passes, they will violently oppose. And after a few months, 6 or 7 months, 8 months, if they say you have corrected something, you have leveled something, they will accept it as self-evidence. So remember these 3 stages everywhere. So 3 stages. There are 3 kinds of people in this world: who make things happen, who watch things happens, and who wonder what happened. Which category do you fall? You think yourself. And confidence is better than perfection. Perfection means doing the best, but confidence means knowing how to handle the worst. And this is in my center, all orthopedic course with Ilizarov. See, dear friends, don't think fail. Fail stands for first attempt in life. And never think that you have end. End never dies. End means never dies. And let us not be satisfied with just giving money. Money is not enough. Money can be got, but they need your heart to love them. So spread your love everywhere you go. For deformity correction, you should have to love your patient and carry home message. I always show this everywhere because I have the evidence that I have shown you. I have the science. I'm working with the science, and I have the skill, surgical skill of the surgeon, that I try my best to do something for the poor people of my country. The terminology is very good. Technology, is very good for machines like computers and telephones. But human body, we need to go a step further. That is called biology. And all technologies have to be biologically oriented. And Ilizarov technique gives this biology. It is not only essential that a costly technique is more advantageous. Let us be the leaders in advocating biological and techniques and mechanical techniques that globe might appreciate, and we can do that. Ilizarov surgery has gained a very strong foothold in my country, Bangladesh, and in world arena. So These are the cages. You know, our poor people, middle class people, you could help. This is the third world in Nigeria, in India, in Bangladesh, in Nepal, even in Russia. See, this is the technique you can do. So I have 78 international publications, international 41, 20 and other things. This is my book. And within a short time, I'm going to publish a book on Ilizarov technique in the upper limb. Thank you very much. I always convey my gratitude to these gentlemen, Professor Gubin, Professor, you know, there is Burjunov, Shved, that I learned from always from them. I must say, all the deformity surgeons in Kurgan Center, if I remember their name, very, very, you know, I must always remember the Professor, you know, Shevtsov, Professor Shigirov, Professor Murjikov, and Professor Ivanov, Toplenki, Novikov, Shikileva, and, you know, the Klushin, Martel, Povkov. They're all deformity correction surgeons. Nowhere in the world you will get a lot of deformity surgeons. This is true. I must give you this message to all you all that what I have learned from the Kurgan Center, that I am decentralizing this to my young surgeons, young colleagues. I invite you all to learn Ilizarov, and you can do whatever you like in your body. Thank you so much, dear friends.
Thank you, sir. If you please stop your screen share, then I can view the gallery view, and so we can see all the participants. And on announcement is that please send your question to me in the chat box, or you can hands up so that I can unmute your microphone and you can connect with my Professor Bari sir. And please just make your question. I will come back to you very shortly. Before going to the question answer session, I want to hand over the microphone to some of the dignitaries for participants from Bangladesh and other part of the world, so that they can have comment to overall the session. And before going to that, I want to make my comment. For Bari sir, the presentation was superb, and to me it is like a living documentary of deformity correction. The cases are very, very difficult cases, and you can see all the planning and how the post-operative and pre-operative. And one thing I must say that your documentation is superb. Many of the surgeons in my country, including me, are very reluctant to take the document. When I prepared anything, many things are missing. Some pre-operative, there's no pre-operative X-ray, maybe post-operative, no follow-up X-ray. So the one thing we can learn from you, documentation, even as I am a student of you from the very beginning, I know that many of the cases you show us are a very long time line follow-up, and all the things you preserve very nicely. And for me, I can say for Bari sir is that you make to feel the Ilizarov surgeon of Bangladesh to think all the time about Ilizarov, to dream about Ilizarov, to do their practice and their earning only depending on Ilizarov. So Bari sir, you are the person who makes us to feel, makes us to dream that you can choose the Ilizarov, only Ilizarov, nothing other technique to do your clinical practice. So now I am going to some other doctors to have comments and short comments, and then we'll go for the interaction session. I am going to Amir Hussain sir to please unmute your microphone and have a comments about the Bari sir presentation, and then we'll go. Amir Hussain sir.
Thank you. Thank you, Bari Bhai. Thank you, as because this is elaborate discussion and the presentation, which is very much enthusiastic and more advanced stage. As because you correctly demonstrate the angulation of the femur and upper tibia, upper femur, lower femur. occasionally there is a deformity in two bone, but we correct the one bone only, and correction is not always performed. So your angulation calculation is very very useful for the Ilizarov surgeon, and I think this calculation may help in the future for better correction of the deformity, varus or valgus. Thank you, Bari sir. Thank you, Bari bhai, for the elaborate discussion and for the new era of education in Ilizarov also. Thank you very much.
Thank you, sir, for your nice comments. And now I am going to one of our foreign participant, Dr. PRS. Please unmute your microphone, and before going to question session, you can comments about the overall session today, our Bari sir presentation. PRS sir.
Can you hear me?
Yes, sir. We can hear you, sir.
It was a very excellent presentation, and as you rightly said, it was a living document and living evidence that how we can incorporate this technology. I mean, generally it is not well taught in your residency periods. Then after residency, you have to learn on your own, because as sir told, many surgeons find it cumbersome, but cumbersome is just an ignorance, because one is not used to that technology. So really, it's a very inspiring lecture from sir, that we should use this technology, especially in this COVID era, when we have the fear of aerosol generating procedures. I think this is the procedure every orthopedic surgeon should learn now, because maybe in coming years, and we have to take it up because of this problem of COVID also. Because if we want to give our patients, biologically oriented solutions, this is the thing that we should go for. Thanks.
Thank you, sir. Thank you, sir, for nice, inspiring comments. And also, now I am searching for Dr. Samsunuda, sir. Samsunuda, sir, if you are online.
Samsunuda is here.
I'm here.
Yes, Samsunuda, sir, please have some comments before going to the question answer session.
Thank you, Dr. Arif. Thank you, Bari sir, for again and again a wonderful learning from you, sir. Whenever I listen to you, I learn so much things from you, and really want to come to you again for listening, sir. It was a very wonderful lecture on deformity correction and awesome examples of very difficult cases of limb length deficiency and deformities. I'll just add the points what I do in very short, that in my patients, when I do a deformity correction cases, first of all, I take a full length X-ray, that is full length scanogram from head to toe. So to compare from the right side, the normal side to the abnormal side. So in a scanogram, we can check for this limb length deficiency, mechanical deviation, and true mechanical and anatomical axis, and the joint angles. So this can be truly calculated only when we have a full true view, full X-ray, that is full scanogram. That is the first point. We must do a first full scanogram. And number two, sir told the formulas of CORA. We can also do with the formula of this the American Dr. Hasenberg's formula, map the ABC. We can also do with that. That really explains about for example, if you see map the ABC, M stands for measure the mechanical deviation, A is to analyze the joint angles, P is to pick the deformed bone, which is the femur or tibia, and A is the apex of deformity of the CORA, then bone cut and then correction. So this formula we should also learn. And what I do in my cases is I calculate all this on my app, on the Bone Ninja app. So this gives me exact calculation and exact surgery virtual correction planning for the patient. So how much I have to do the correction, how much I have to do the LLD, how much I have to correct the rotation. So these four things one must remember: do a full length X-ray, calculate, as sir said, calculate all the deformities, joint angles, the deficiency, and if you can get it, you can use a Bone Ninja app for that. Thank you, sir.
Thank you, Dr. Samsuluddha sir, for sharing your own experience also and have nice comments about the Professor Bari sir lecture. And now you know that this the session is lively telecast on YouTube channel of Dr. Samsuluddha sir, Ortho World, and also Ortho TV Live, and you can enjoy that from that link. And you are all happy to know that every day after the session, me and Dr. Samsuluddha sir usually upload the videos of today's lecture on our YouTube channel. Please subscribe our YouTube channel, that is Ilizarov Clinic KUMC and Ortho World, so that you can get all the update of the lecture just at the time it's uploaded. And now I am going to Dr. Indralin Datto. So far I know he is from Kolkata. Please unmute your microphone, and if you want to pass some comments, please you can communicate with us. Dr. Indralin Datto, can you hear me, sir? Dr. Indralin Datto, can you hear me, sir? Okay, I think we can get to him later on. Now I'm going to some of the friends of us from Nigeria. You know that this webinar a little bit international, going to the international platform. The many peoples from India, Nepal, and the Middle East, and also from Nigeria, they are joining with us, and we can have some comments from them. If you want to just pass comment, you can put your hands up, or I will just randomly select some doctors from Nigeria so that they can got connected with us. Sorry. So I am. So I am going to Dr. Keen. Dr. Keen, if you can hear me, please make your comments. Yes, sir. Dr. Keen, please give your introduction.
Yeah. Can you hear me?
Yes, sir.
Can you hear me?
Yes, sir. I can hear you, sir.
It has been a wonderful presentation and a session that cannot be quantified in any way. I've been longing for this particular session, and it has justified my waiting period. It's a wonderful presentation. I commend Professor Bari. He has shown his expertise, and he brought his knowledge to bear. We've all benefited from it immensely. In fact, I can also see that indeed he's a guru in this area. There's no doubt about it. I want to commend him for being a mentor to the younger ones. He has shown that indeed those who are ready to learn, he's also ready to impart the knowledge. These are the kind of people we long to see, and we pray for long life for them so that we continue to tap from their wealth of knowledge. Thank you so much, sir.
Thank you, sir, for your nice comments. We always pray for Bari, sir, for his long life, and always his blessing to us for his teaching and for his encouragement. And now I think I will go for the question answer session because it is already 1.5 hours past since we started the webinar. And for you, I just seen one from Dr. Rashid Hassan Rani, and he have a question to the speaker. Dr. Rashid Hassan Rani, if you can hear me, please, please.
Yes, I can.
Yes, to directly to Bari, sir.
Yes, I can.
Yes,
okay,
sir.
Okay, thank you, Dr. John. Am I audible, sir?
Yes, sir, you are audible.
Dr. John?
Yes, we can hear you.
Okay, thank you. First of all, I want to convey my respect and congrats to Professor Bari, sir, for his very, very excellent presentation, which was full of rich content of topic and very much palatable form also for us. Sir, Assalamu alaikum, sir.
Wa alaikum assalam.
Sir, I want to ask a question to learn from you. Sir, is there any chance of displacement at osteotomy site during deformity correction? If that, then how or what measure we can take to prevent displacement osteotomy site during correction? Sir,
Yes.
am I clear, sir?
During osteotomy, if I do any displacement, how could you take measurement? Okay?
Yes, sir. Yes,
This
sir.
is,
Yes, sir. Yes,
this is, you know, your question, this is general question, good question. But for doing any surgery, especially the, as for example, if you put the hinges, deformity, varus or valgus, put the hinges fast. Listen, put the hinges fast. And then you do the osteotomy, then you will not be able to displace the bone. If you don't put the hinge, that means rod and hinge, do the osteotomy, you will make a displacement. This is very simple answer. So before doing any osteotomy, place the hinge fast, then you will be able to do the osteotomy and there will be no displacement after placing the hinges. You understand me?
yes, sir. Thank you, sir.
Rashida sir, do you have any comment?
Yes, sir. I have additional questions, sir. Sir, with your permission, can I ask one more question, sir?
Yes.
Sir. Yes, thank you, sir. Sir, is there any chance of recurrence of deformity after correction? If that, then how can we prevent recurrence of deformity?
Meticulous, intelligent follow-up. And recurrence it can be. Patient can come to you with the problematic second time breaking of the regenerative bone come. You must, that's why before surgery, after surgery, I have mentioned something for the patients also. So you must be meticulous, you must be serious with the patient, and if it does happen, then you should have to tell your patient, go in this way, and you should have to do it again. Okay? Recurrence
Thank you, sir. Thank you, sir.
Thank you, Rashida Sir, for nice introduction. And now, sir, with your permission, I want to share my screen so that on doctor from Nigeria, he sent me some photograph for discussion in this session, and Dr. Adekunle Adebanjo, and I asked him to unmute and he can directly question. I am showing his screen. Please unmute Adebanjo sir with your introduction, and I am sharing the screen. Yes, I am sharing my screen.
Wow.
Sir, can you see the X-rays, sir?
Yes, yes, yes. Lateral view.
Yes, sir. I am showing the all
lateral view.
This X-ray are sent by our Nigerian friend, and for his comments regarding this is AP view X-ray, and this is the clinical condition of this patient, and this is the last clinical photograph.
46, again,
this is AP, and this is 9 years old, and I'm going directly to the doctor Adekunle, so that I'm my sharing. Please, unmute your microphone if any.
Yeah, I've done that.
Yes, stop. Okay. Okay, sir. You have seen the X-ray, and
I have seen now. Now I have X-ray quality is not too much, you know, too much good. Even then, I willing to pass my comment. See, the age of the patient is 9 years. Okay.
No, sir.
No, patient is 46 years.
So he's telling 9
injury
years.
Is 9
sir. Injury is 9
the
years.
Injury is 9 years.
Oh, injury is 9 years, 46 years. Then listen,
yes.
How much shortening of the patient? Of the limb shortening?
About 6 centimeters.
6 centimeter. Listen, you can go for ankle fusion, denude the lower end of the tibia and the talus. You have to see the subtalar joint also. If subtalar joint is affected, then you could go for triple orthodesis of the ankle joint and lengthening in the top. Make 5-degree angulation in valgus little and go for lengthening metaphyseal region of the tibia. This is my suggestion by seeing the X-ray. Okay.
You can also see that the Achilles tendon is very contracted.
Achilles tendon is, if it's contracted, you can go for very easily double step or triple step tenotomy for going the Achilles tendon correction, and gradually you will pull with hinges from the back side, distraction. Okay.
All right.
This is a very good case. These are the common cases that we're getting all the time. Don't worry. Ilizarov,
do you have any
only K wires through the talus and the there? Don't worry. You don't need to inside put any hardware, because 9 years patient is not getting any white, giving white beards. Bone quality is not good. The biocompatible thin wires with Ilizarov fixation will be better, and you will get a new bone. Bone quality will be good. New vessels, skin color will be changed. Vascularity will regain. Lot of things by Ilizarov. But if you put something in the inside, you cannot, get a good result with the bone quality. Bone quality, 9 years not giving any pressure. So you must think yourself, the bone is osteoporotic. Bone is not good. Okay? You are satisfied or not?
Sir, Adikunle sir, if you have any complimentary question, you can ask, sir.
I see Dr. Anand is willing to tell something.
Okay.
Yes, sir. I'm going. Okay, sir. Thank you, sir.
No complimentary questions before you leave me.
Okay.
Yeah, other questions.
Sir, please.
Please unmute.
Can you hear me?
Yes, sir. We can hear you. Yes, sir.
Yes.
Okay. Some of the pictures Professor Bari presented, some of them are not full length. They are not scanograms. I just want to ask, is it full length compulsory, or you can just assess, because sometimes you don't have access to do a scanogram.
Dear friends, listen. I do here in the center all the full length, 33%, 33%, 30%, I can compare. And individually I take the full length of the both sides, affected and normal side.
No, my challenge is that in some centers you can't have the full length. Will it affect what you're going to do? In some centers, you can't have the full length.
It is better. If you do full length, it's better. Otherwise, outside you will have to calculate, measure everything. Eye estimation. That will also help.
Okay.
Okay.
Last question. Question.
Yes, sir. Please go.
How do we get some of those your books? Very good books for beginners like us. How do we get some of those books?
You come to my place and you'll get it. You can talk with Emba, Wahabinusa.
Yeah, I know Emba.
Emba, you talk with Emba. He will give you, and you could take Emba. He has got, and Wahabinusa. Okay. And Obinna, you know Obinna?
Yes, I know Obinna. I know.
Emba, you talk with them. They will help you.
All right.
Sir,
okay,
I think you are getting popular in international wide also. So I think
no, no. Everything with Allah, everything Allah. Sir, no, you are helping me. You are all my friends. I love all these people.
Sir, your book should be a soft copy or a one-line copy, so that
yes, that two books you can get from online, free. That is lower limb and pediatric compression distraction. 2 books online, you will get all the time. From you see Medcrave American Journal from online, you can publish. Get that one.
Adikunle sir, I think you got the answer that you can get some books also from the online.
Medcrave, you search Medcrave, Dr. Bari, then you will get 2 books.
Yes, sir. Now I am going to Dr. Anand. Dr. Anand, please unmute your microphone and please your question to.
He is a spine surgeon now.
Okay. Can you hear me?
Yes, sir. You can hear you.
Yes.
Okay. Thank you. Thank you very much. First of all, thanks a lot to Kurgan Fellow Group for arranging such a nice discussion here. And every discussion I am enjoying from the first day. And especially thanks to my friend, Dr. Arif and others. And the great magician of Ilizarov of Bangladesh is Professor MM Bari, sir. Sir, very good evening and assalamu alaikum, sir.
Wa alaikum assalam wa rahmatullah.
Actually, I have many sweet and green memories with you, sir. During my resident period, and several times I went to your palace. I have a question, first of all, to you, and then I have another consultation about a patient with Dr. Shetu. I think Dr. Shetu is here.
Yes, Shetu is here, sir.
Okay. Okay. First of all, I have a question to Bari, sir. The question is, sir, tropic ulcer, that is neuropathic ulcer, due to old spine cause. Old spine cause, is there any role of Ilizarov without spinal intervention?
Yes.
Okay.
Ulcer in which place?
In the sole.
Sole of the foot. Yes, there is a role. Because
okay,
you can create a new vascularity doing a osteotomy and bone transportation in the lower tibia, if in the sole. If in the sole, you can do that.
Old spine.
And at the same time, you shall have to take the help of the plastic surgeon.
Okay, okay, sir.
Both.
Okay, thank you, sir. Now, Dr. Shetu, sir,
Yes.
I have a consultation with you. A patient, a male patient, 27 years, you have done a very nice operation of upper limb.
Sir, do you want to share your screen, sir, so that we can see the photograph? Do you want to share your screen?
Yeah. I am showing. It is about 4 months ago you did this operation, and about 2 months back the patient went to you for follow-up, and now this is the X-ray I am showing you. This is the lateral view.
Please share your screen.
So
we can see.
My advice to Dr. Anand, please have a good photograph of your patient X-ray, and you can send the X-ray directly to Dr. Nazmul Huda Shetu's WhatsApp, and you can have the opinion and your consultation later on. And thank you,
and now,
sir, for connecting.
Arif, now is it possible to see just now? Hold, we are also interested.
Sir, okay. Sir, can you focus your mobile camera closer to the viewbox?
Yeah. This is the latest X-ray. This is the AP view. Can you see it?
Sir,
yes.
This is the.
Can you make it a little bit bigger? Can you do it?
Sir, yeah.
Sir, I think
yes.
Please take a photograph and send it to us. Even you can send to message box. Message box.
No,
we cannot see
not visible. Good.
Okay, thank you, sir. Thank you, sir. Now, if we have, I'm searching for.
Doin. Arif, Doin Wenusi. Doin Wenusi is waiting for asking questions.
Yes, sir. I'm searching, sir. Yes, sir. I am. Please, Doin sir, please unmute your microphone. Yes, sir. Have your introduction and you can have your question, sir.
Okay. Good day, everybody. My name is Doin Oyenusi, and I wish to say thank you to Professor Bari and all the other people that have presented. Although I came a bit late, I'm a practicing orthopedic surgeon here in Nigeria. I work for the military, and my interest in Ilizarov was sparked off about 7 years ago when I was working in Israel with Mark and Dr. Esbach. But on getting to Nigeria, Ilizarov hadn't taken off. But thanks to the likes of Dr. Izuagba and Dr. Adebanjo and the rest of the team that are sparking up the interest. The only concern that I have right now is that the hardware is not very common here in Nigeria. Getting it is not very common. So in Bangladesh and India, where I know that Ilizarov has been around for some time, and I know that your hardware are not as expensive as you have in the West. Maybe there we need to have more collaborations and bringing this thing around, and even invite you guys around to come and, participate in our seminars. That will really be rich. I look forward to such a time. Thank you.
Thank you, sir. We got your question, sir. Should I repeat his question, sir?
No question.
Sorry, he have a question that he have a question that he cannot get good quality of implant in Nigeria, but the Bangladesh and India are getting the implant. Even they have their own manufacturing ability to have the implant. How can they get implant in Nigeria? And what about the collaboration between Bangladesh, India regarding the implant? Just his or just general statements, sir. So now I in chat box there is a question from I do not get the ID. Just PC is just mentioned here. Maybe he logged on from his desktop. Sir, a question to you: many of the surgeons in home and abroad doing different modification like hybrid. What is your opinion regarding this, sir?
See,
yes, sir.
Yes, I'm telling you. The message you should know. The man who is trained up with hybrid, he will follow the hybrid. If you want to marry, you are from Nigeria, you want to marry a Bangladeshi girl, that will be a hybrid. It will be good or bad, you think yourself. If you are Indian, you want to marry a British girl, hybrid makes problem at the old age. Hybrid, what is hybrid? The product of a cross between genetically unlike individuals. This is called hybrid. Yes, sometimes you cannot avoid the hybrid all the time. But once you are doing Ilizarov, you must follow the principle of Ilizarov. Everywhere you're putting all chance and you are telling that you are doing Ilizarov, I cannot agree with this. I cannot agree with this. Transosseous. The name of the system is transosseous osteosynthesis. Hybrid you can put in the upper femur. That doesn't help. That does not create any problem. A little bit you can put the chance why it is not possible. But why is the tibia in the possible? Why you are putting hybrid? This is my asking. I have trained up from Kurgan. I told you the origin of deformity correction started from Kurgan, but book of the Dror Palais Principles of Deformity Correction, it was written in 1992. Ilizarov did all this everything in 1951 and later on. Now think yourself, this book is good, Dror Palais is good, and latest book are coming is also good, but principles of, if you do Ilizarov, you must follow the principles of Ilizarov and philosophy of the Ilizarov. Hybrid, those are doing hybrid, let them do hybrid. But I don't follow the hybrid principle. This is my opinion. You can do whatever you like. Fundamental principle of Ilizarov methodology is load and motion. Rigidity and elasticity, this is not the same. The Ilizarov wires or K wires always flexible. A chance, this is not flexible. You're making big holes. That is the difference. 1.5, 1.8 and 2 millimeter K wires, when you are drilling, this is the principle, you're increasing circulation. Now think yourself, decide, you decide yourself which one is good. You understand me? Am I clear to you?
Yes, sir, clear, sir. And thank you everyone for having a nice interaction. And for those who are very much interested in Ilizarov, manufacturing the Ilizarov apparatus in their country, and you know that at the last part of our presentation, maybe the last day, there is the quality of the implant that are manufacturing in Bangladesh. We can have a discussion on this and we can share our knowledge You know that at my first presentation, I just focus on some ideas that how the implant are made, are manufactured in Bangladesh. So if you get connected on the last session of that session, we can have good discussion about how to improve and generalize the good quality implant. Even how can we get the Russian implant and other things, we can have discussion on that session. So please stay connected. And if you have any question, then we will go for the question. I still getting the Dr. Anand hands is up. I think if he have any question, he can ask. Or
Richard, Arif,
yes,
Richard
sir?
is going to ask something.
Richard, so just
Mr. Richard.
Okay, sir. I am just searching, sir. And I am very much interested to hear from Indranil Datto. So far, I cannot get connected with him. Indranil Datto, if you are in online or in, if you can talk with us, you can connected with us.
Hello.
Indranil Datto. Hello.
Meeting please.
I am searching for Richard, sir. Richard. Okay, sir, I got him. Please, Richard, sir, please unmute your microphone and have your question. Richard, sir. Richard. Hello, sir. We can see you. And please unmute your microphone. Richard, sir. Please unmute your microphone. Yes. Yes, Richard, sir.
Richard Omeyeni.
Hello, sir.
How are you, sir?
Richard, sir. Yes, we can hear you, sir. Do you have any questions, sir?
Can you hear me?
Yes, sir. We can hear.
Yes.
Can you hear me, sir?
Yes, sir.
Yes.
We can hear you.
Yeah, I just want to commend the presenter.
Sorry, sir. There may be some
problem.
Sorry, sir. There is a communication problem.
Incidentally, some of the cases presented by Prof we've had such cases in my center.
Yes, sir.
And can you?
Sorry, sir. We cannot hear you. So now I am coming to the end of the session. So I am going sequentially. I just found that one of our Kurgan fellow, he done his fellowship just after us, a master's course in Kurgan, Dr. Arun Sarkar. He is with us. I am welcoming him. I will go from Arun Sarkar, then some of our Kurgan fellows. Then I will go to Dr. Samsuluda sir for some for stopping the live transmission. And if you don't have any question, we will go through this sequence and end our session. And there are some messages in the chat box. Okay. There is a question, sir. So it is an elaborate question from Dr. Ghulam Mustafa. You can directly ask to the sir and about dressing protocol. Now I am going to Arun Sarkar, then Dr. Ghulam Mustafa, be prepared, and Dr. Nazmul Hoda, then to Bari sir, and then Samsuluda sir, and then back to me. We will end up our session. Dr. Arun sir, please unmute your microphone, and if we are connected, Arun sir, can you hear me, sir? Welcome you, sir.
Welcome.
Yes, sir. I can hear you. I can hear you.
Can you hear me? Can you hear me?
Yes, sir. I can hear you, sir.
Thank you very. And first of all, I like to give my thanks to Professor MM Bari sir, our respected mentor. Actually, I missed the previous lectures. Actually, I was sick. Actually, I took some nebulized salbutamol. Actually, I missed those lectures, but here I have seen Professor Bari sir is a very nice, elaborative, a pictorial, video-assisted, informative gorgeous and titanically illustrated presentation. Thank you very much, sir, for
Thank
your
you.
nice
Comments.
well as well.
And
thank you
for your information,
Dr.
Arun sir, you can get all the lecture from YouTube link of Ortho World and Ilizarov UMC, and you can enjoy as much as you can, as much times. So I am Sarshita Richard Omioni sir also hands up for another time. Maybe he have some question. He has some question. Research sir, do you want to communicate? Please unmute your microphone. You can communicate. Research sir. Okay, sorry. Now I am going to Ghulam Mustafa. Please unmute your microphone and you can have your question. Okay, Ghulam Mustafa sir. Research sir, if you are in online, you can send your question to the message box, so that as the connection is very poor condition, so you can send the question in message box, sir. Ghulam Mustafa, can you hear me?
Yes, I can.
Yes.
Can you?
Yes. Please throw your question and also comment, and please make it short, so that we are at least 2 hours from the beginning, so we can have a good end very shortly.
Okay, thank you, Arif.
Yes.
Thank you, sir, mentor Professor MM Bari, sir, for your nice and informative presentation, and in an easy way. Sir, my question, please say elaborately about your dressing protocol, sir.
Dressing protocol. If you do the surgery anywhere in the femur or in the tibia, if you think that this is very big surgery with a little bit big incision, with proper dressing, first day you have done, okay, you done the surgery, next day you must do it, the dressing, next day you must do it. With, I personally use all the time with spirit, like Russians. I like the spirit, and I do the dressing all the time with spirit. Sometimes with hexisol, that is called chlorhexidine, but whenever you use betadine or hexisol, there is burning sensation. If you spray it, very cool, and easily you can disinfect that area. And after every, if no problem, 5 to 7 days, even 10 days, I don't touch the patients. You don't need to do that, not all the time. And the spirit is good. If you don't have a spirit, you can use normal saline, but properly dressing. And this is your ring, for example, this is the wire, this is the wire, this is the wire, and encircle the whole dressing with rubber stopper. Lot of Ilizarov surgeons, they never use the rubber stopper. This is why, I don't know. This rubber stopper gives two things. Very easily two things. Whenever your skin wire interface, you're passing the wire through the skin, and there is a small incision, sometimes incision, or sometimes a small hole. When you put your rubber, it prevents skin wire interface micromotion. Number one. Number two, whenever you're covering the rubber stopper, it looks very nice. You cannot open this room window all the 24 hours open. What will happen? If 24 hours will open, here coronavirus will come, all virus will come, then what will happen to that area? So proper dressing is very important, so that patient can work with this dressing very nicely. Somebody can tell, oh, fantastic dressing. Counseling, and I have written a book that is called How to Live a Life with Ilizarov Frame. How to Live a Life with Ilizarov Blade in Bengali I have written for our patients. I give the instruction, read them. Please, you read it. I will take your examination before discharging. And I ask most of the patients, we tell them, our nurses and brothers tell them, and at the same time I ask the questions to the patients so that they can do it. Sometimes it happens, most of the illiterate people, those who are coming from village, we are facing problems. It is everywhere, not only in my country, in Nigeria, in India, everywhere, third world country people, So proper dressing, proper physiotherapy is very important. Fundamental principle, I tell you all the time, put the wires, you tell your patient to go for loading. Loading gives you the vascularity. When your wires are there inside the bones, this is coming micromotion, fundamental means micromotion. It creates vascularity in the whole limb. So proper dressing is very good. Try to respect the whole ring area. Cover with gauze, whole ring. Every ring you should cover wires, every ring, so that nothing is visible. Those who have gone to Kurgan, you have seen so nicely, beautifully it looks. Our black, black skin open with wires, it ugly, looks ugly. So that's why you must cover it so that it looks nice. Am I correct?
Yes, sir. Thank you, sir. And sir, there is a session, and there is a session later on the pin-tact care. I think we can elaborately discuss on this because pin-tact care is a very good chapter for us. Sir, there is a question for you in the chat box that from Richard sir. I will like to know how closely you work with physiotherapists, especially for the rehabilitation of the patient, sir. It is question from the Richard sir.
Yes. I have a rehabilitation center. I have 2 physiotherapists. I check myself. I go to the physiotherapy room every day. And whenever patient coming with the apparatus in the tibia and in the femur, I send them to the physiotherapy room to go for exercises. And I have in my room also one machine. If in the tibia, I tell them, please do your exercises. Patient is doing exercises. Am I looking how much? 100 times he's moving. And by this time, I'm looking another patient. And it helps because in presence of me, when I instruct the patient gets satisfaction. In presence of doctor, I'm doing this. You must control this one. In Ilizarov patient, physiotherapy is mandatory. Is mandatory. If you don't do it, outcome would be not good. Motion.
Thank you, sir.
Our main target motion. Okay, thank you.
Yeah, there is another question from one of our Kurgan fellow. I think this question is very much relevant for now today's contest. In this corona situation, we know that the virus lives on the metal for 3 days at least. So how to take care of things, sir?
Oh, dangerous. Don't do anything. Try to leave. Then you can do a lot of Ilizarov surgery. I don't do it now. I am afraid of. I want to leave, but I don't know what Allah will help. I don't know. So don't do avoid. If it is not emergency, only do the reduction and nothing. Even if you don't do, take rest 2 months, 3 months, no problem. Then you do. Shamsuluddha is making a lot of money. He's doing. That is another thing.
No, sir. Only emergency cases, sir.
Only emergency.
Thank you, Dr. G.M. Munir, for making some funny question and also have some refreshment in that part of the.
I see Hamidul. Where is the Hamidul? He has left.
Sir, Hamidul. Okay, I cannot find him. So now I'm going to Dr. Nazmul Huda Shetu, then going to Amir Hossain sir for concluding comments. And Nazmul Huda Shetu, please have some comments in short. And we are already 2 hours. 2 hours have.
Nazmul Huda just like you don't mind. He just from here he looks like a Saddam Hussein.
Thank you, sir. Thank you, sir. Thank you, Arif. Actually, I again thank you to our great sir, Bari sir, and his lecture will be the great asset for our future generation, and we should keep it in our YouTube and always follow this lecture. And within this short time, the vast chapter will be concise very nicely, and most important things everyone can get from this lecture. So everyone should follow this, and we should keep this YouTube very carefully. Thank you, Arif.
Thank you, sir. And for your information again, you can go to YouTube, Ortho World and Ilizarov Clinic KUMC for the previous lecture. And for Now I am going to Amir Hussain sir. Please have some short comments, and we will go to Samsul Huda sir. Amir Hussain sir, please unmute your microphone. Amir Hussain sir, please unmute your microphone. Yes, yes sir, we can hear you.
Thank you, Dr. Arif, and also thanks a lot to Bari Bhai and all other participants who are enjoying this enthusiastic lecture and discussion of Ilizarov, which is growing a lot in our country, and many of the very difficult deformities are correcting by Bari sir, and also many of our Ilizarov surgeon. I am much that we are going by webinar lecture and discussion weekly, and also learning for new generation of Ilizarov surgeon. Thank you very much. Thank you. Thanks a lot of all participants of Ilizarov from Bangladesh and abroad. Thank you.
Thank you, sir. Our initial motto about this session is that to just encourage the new comers of the Ilizarov surgery and the beginners, so that we can always share our knowledge, and also the experienced one, we can refresh our knowledge, and we can share our experience from the surgeon of home and abroad. So there is another 12 lecture left. Everyone I request to connect it, and there is one announcement that Samsul Huda sir just posted the link, all the link of the YouTube channel. You can go through the link in the chat box, so that you can go directly to the YouTube channel. And now I'm going to Samsul Huda sir. Samsul Huda sir, please unmute your microphone. Samsul Huda sir, can you hear me, sir? Samsul Huda sir. Samsul Huda sir, can you hear me?
Where is Kamrujaman Manik?
Samsul Huda sir, can you hear me?
He's here.
Sir, here, but I think there is a connection problem. I already sent the host status to Samsul Huda sir, so that he can end up the live on YouTube, and I think he is doing that job. Before Samsul Huda sir, can you hear me, Samsul Huda sir? Sorry, Samsul Huda sir, just make a WhatsApp call to me. Hello sir. Oh, sir, I already sent the host status to your previous ID. Okay, sir. Yeah. Oh, sorry, sir. Nazmul Huda Shetu, please unmute. Yes, sir. I'm doing that, sir. There is co-host from our part. Okay, but sir, I already sent the host status to your previous mail. So.
Hello.
Okay. Please send it again. Yes, sir.
Hello.
Sorry, sir, for some technical problem. Samsul Huda sir is just offline, so that he cannot communicate with us. And Nazmul Huda, can you hear me?
No.
Nazmul Huda sir.
Yes.
Sir,
yes.
please check the participant list. Samsul Huda sir sent a request there. Please admit this.
Yes, I have already admitted him.
Oh, okay. I think we'll get back to Samsul Huda sir because I sent the host status to him, but his ID is just hanged, and because it is very necessary for YouTube and other live transmission to stop.
Okay.
Samsul Huda sir is connected. Have you got that? Samsul Huda sir is connected.
That is stuck. He is just like this, stuck. Harun Rashid is willing to tell something.
Then
Harun.
Please, Nazmul Huda Shetu sir, please unmute the Harun Rashid sir. Okay, please admit Samsul Huda sir. Okay, I am the host again. So, Samsul Huda sir, are you here? Samsul Huda sir, are you here? I can get the Samsul Huda ID again. More. Samsul Huda sir, can you hear me? So just I apologize for this technical error, and just wait for a few minutes. We'll stop our webinar session. And before going to that, I am going to Harun, AKM Harun. If you have any question, please ask, or you can communicate.
Arif, please make me host.
Okay, okay, sir. You are back.
I'm back.
Okay, sir. Sorry, sir. Okay, I make you host, sir. Okay.
Yeah.
Already I sent the approval, sir.
Just wait, just wait. So I'm stopping the live session, okay?
Okay, sir. And also have some comments over the overall session, and we'll go to the.
Yeah. Okay, okay. Thank you, everybody. Thank you, especially Baris sir, for a wonderful, wonderful session. Again, as I've all done, we have had a very good learning. We'd like to learn from you again and again and again on this youth webinars, and physically I used to come to you. Thank you, Dr. Arif, for wonderful webinar sessions. So now, after this, I'm ending the live YouTube session. Thank you.
Thank you very much.
And you everybody know that Samsul Huda sir is always a very good friend to us, and he just mediate all the things to live telecast of this event to Ortho TV Live and Ortho World, and we are very much grateful to him, and also to the authorities of the Ortho TV that they are telecasting our the events. And you everybody know that our tomorrow session again on the deformity, and it will conducted by Dr. Nazmul Huda Shetu, and you will get the different views. And also you know that Bari sir just completed all the things. It is very difficult for the successor of Bari sir or the follower of Bari sir to give lecture on the same topics after him, but I think Dr. Nazmul Huda Shetu can focus some very important and
Dr. Arif, I made you host.
Yes, sir. Yes, sir. I got that. Then
so
please,
thank you, everybody. I'll be leaving the meeting now to move ahead.
Yes, sir.
Please leave.
Yes, sir. You can. Yeah, definitely, sir. Thank you, sir.
Thank you. Thank you.
Yes, sir. So please stay connected for tomorrow. The same time, same session, same password, same ID. And now, with the permission of Bari sir, though Bari sir is the speaker, but we always check the permission from him, because we all are his student, and we just keep in mind that he is our mentor and respect him. And thank you again, sir, for your nice and super presentation, and especially the clinical experience. You got the experience of more than 20,000 cases in your long clinical career. So every time, please enrich us, because we are just beginner in relation to you. So I expect very good experience sharing from you, and also very much thankful to you, because all the previous 11 session you are always with us. Even if for a single minute you do not get disconnected or get offline, and for your continuous support and appreciation, sir, we salute you. And if you have something to say, please please tell us, and then we can end the session, sir.
Thank you very much, everyone, my foreign friends and my junior colleagues. I want to always learn something from you. Your, body shaking, your mode of speaking, how you look to me, how you look to you. And this everything I want to learn. I want to learn from the juniors always. New things are coming up, And what I know, I want to decentralize everything to you. And that is my satisfaction. Want to laugh? A doctor is always a student till his life. Always. When he doesn't want to be a student, he dies. This is the theory. Doctor is always a student. If you think that I know everything, no, this is not good. Every day I'm learning from you. Juniors they know better than us. Sometimes they know better than us. So this is, thank you very much again. And you will carry the flag of our country, Bangladesh country, to everywhere. See a lot of foreigners coming. That is good. Very good, Ita. This is not a matter of joke. This is a very important thing. See, all our Nigeria. How many Nigerian friends? Now all Nigeria, they know where is the Bangladesh. Thank you very much.
Thank you, sir, for your nice words. And especially thank to the Nigerian friends. Please stay with us. Bangladesh is one of the fan of your football. Everybody in Bangladesh likes the Nigerian football team. And also we are
yes.
From now we are very much admired to the people of Nigeria because, sir, you don't know, many of the messages every day I got from Nigeria about today's session, what will be the next session, please send me link, and their kindness, and they express their thank to me and to Kurgan group, and from my word that I want to say that we are trying to deliver the most basic level and also the advanced level and different all the details, that all the knowledge that we got from Bari sir, from the Kurgan center, and from our very small clinical practice, all the knowledge we get, we want to deliver here, because if you deliver your knowledge, it will not get short, it will increase, and you can get also the return from the other, as my Professor Bari sir told that you can learn also from your students, from the other peoples. Different people have different views, and as this webinar is an international platform, we can get different views from the different person also. So thank you all for being with us with patience and with your attentiveness. Tomorrow we will come back again in the same time. And now, from now, it is goodbye from me, and assalamu alaikum. See you tomorrow. Assalamu alaikum.
Wa alaikum assalam wa rahmatullah.